Okay, welcome everybody to this meeting of the Health Overview and Scrutiny Committee. It's taking place in the Council Chamber at County Hall, Glenfield, but some of the officers will be joining online via Microsoft Teams. And the meeting is being broadcast live for the public on YouTube as well, so it's still a public meeting. As this is the first meeting of the new council following the election, I'd like to welcome all the new members to the council and the new members to the committee as well. We've got a few new members here, I see. And I'd also like to welcome the new Cabinet Lead Member for Health, Mrs. Louise Richardson. Okay, so the first agenda item today is appointment of chairman, and this is for the 2021-22 year. Mr. Jonathan Morgan was nominated as chairman-elect at the council meeting on the 19th of May. Can I have a proposer and seconder, please, that Mr. Morgan be appointed as chair? Thank you, and a seconder? Thank you. Okay, Mr. Morgan, you are now appointed as chair of the Health Scrutiny Committee for the 2021-22 year, and I'll hand over to you for the rest of the meeting. Thank you.
Thank you very much, Ewan. That's very kind of you. So we now come on to item 2, which is the election of the deputy chairman. Do we have a nomination? I nominate Mr. King, Phil King. Can I have a seconder? Thank you very much. In that case, we only have one nomination, and I can confirm if everyone's in favour, then Mr. King is the vice chair. Okay, thank you very much. So we're now on to the minutes of the meeting held on the 18th of March 2021. I think I'm right in saying there are actually only 2 of us that are actually we're at that meeting, who are still actually on the committee. But I'd like to propose that the minutes of the meeting held on the 18th are taken as read, confirmed and signed. Is everyone in agreement? Yeah. Okay, thank you very much. So on to item 4, question time. We haven't received any questions from members of the public, so on to item 5, which is questions asked by members under Standing Order 7.3 and 7.5, and no questions have been submitted. So on to item 6, to advise of any other items which the chairman has decided to take as an urgent elsewhere on the agenda. There are no urgent items. So we're on to item 7, declarations of interest in respect of items on the agenda. Can I ask members to declare any interests that they may have on any of the items on the agenda? Nope. Okay, we have no declarations. So we're now on to item 8, declarations of the party whip in accordance with Overview and Scrutiny Procedure Rule 16. Can I confirm that whether there are any declarations of party whip? I'm looking at our 2 single members. It's probably quite difficult to actually have a party whip. But as far as the Conservative group, absolutely no declarations. So that's fine. So we're now on to item 9, presentation of petitions under Standing Order 35. I haven't received any petitions. So we're now on to the main segment of our meeting, which is item 10, community services and place-based plans. So actually, I can see that you're on the call. The report holders are dialing into this call rather than actually joining us in the main chamber. So welcome, Rachna. You're obviously the Executive Director of Integration and Transformation at the LRR for the CCG, and you're giving us a verbal report. I think we're probably going to allow up to 20 minutes or thereabouts, hopefully for you to go through your report, and then we'll go straight to questions. And hopefully that will give us an opportunity to tease out any additional bits of information that come from your report. So over to you, Rachna. Thank you very much.
Thank you, Chair. Good afternoon all. My name is Rachna Vyas. I'm the Exec Director of Integration and Transformation, and I work across Leicester, Leicestershire and Rutland clinical commissioning groups. We're asked to come today to give an update on some of the community services work that we've been doing and some of our place-led plans that we're working in partnership with Leicestershire Council, County Council on. So I'm just going to give a brief verbal update, Chair, and then invite questions based on the update that I'm going to provide. So really, I've split this into two separate items for discussion. The first, you'll be aware, we launched a community services redesign programme many months ago, and this was well before COVID. And we had started to progress some work about what the shape of services should and could look like in partnership with our patients and our council partners across the course of the last few years. Of course, since then we've had the pandemic, and so all of our engagement processes were paused, and indeed the entirety of the redesign process was also stopped. Actually, what we have managed to do through the COVID pandemic is learn an awful lot about both the services that we provide already, the services that we need to provide going forward, and the services that our populations actually want and where they want them actually. So we've had a huge amount of engagement over the course of the last 12 months and a lot of feedback from our patients, both negative and positive. But the messages that we're hearing by and large are still that our public and our citizens want services provided close to their homes or in their own homes where possible and where safe to do so. They want them designed by themselves and not by, as one lady put it, an NHS person in a suit who's never had to experience any of these services. And we've really taken a lot of that on board, and an awful lot of that learning through COVID has also got to be taken on board in terms of what our patients now require of both NHS and care services. So if I can give you a very live example, before COVID hit, we didn't have a service called the pre-transfer assessment service, effectively. So if you're somebody living out in the county, largely those with multiple long-term conditions and perhaps of older age group, and you called 999, you would more than likely be transported into one of the hospital sites. You'd probably have a 2-week stay in the hospital, depending on what was the issue, and you'd be discharged out with a whole heap of services from our county council colleagues. Now what we've got is a pre-assessment service whereby our EMAS colleagues talk to a geriatrician, so somebody who's very used to dealing with multiple conditions, and the patient's GP, and where possible using technology, the patient or the family themselves. And we've been able to keep 80% of people at home. And these people have not then readmitted or not gone into further hospital services going forward. So the patient experience, the family's experience, and of course the service experience that those patients are getting is much better than they would have got previously. So we really want to build on services like that. And of course we stood those kind of services up in COVID to make sure that patients didn't attend hospital when they didn't need to because of the pressures that the hospital were facing. But actually our service users, patients, citizens, and particularly actually the families have found that services like that are absolutely the right thing to do going forward. So that's what we'd like to build on. So we've got all of that work going on in terms of service learning effectively from what our patients have told us through the pandemic. At the same time, we've got this concept of the integrated care system, which is the ICS, as you'll hear it colloquially known, which is effectively health and care coming together on a wider footprint to deliver services that are right for each area. So you'll hear terms like system, place and neighbourhood, which of course are complete constructs from a planning perspective. But our system is Leicester, Leicestershire and Rutland. Our place actually, so place for Leicestershire would be the Leicestershire County Council border effectively, and that is how we would plan services in partnership with our county council colleagues, particularly thinking about health services and social care services, of course, which have a completely symbiotic relationship. Underneath those two, of course, you've got what the NHS terminology is neighbourhoods, which I appreciate doesn't work, but it's effectively groups of communities or communities whereby we would want to deliver some of these services. And that links to what I've said right at the beginning of this, of making sure that we've got services that are right for individual communities. So if you take those two things together, it gives us the opportunity to then start doing planning on a much more granular footprint. And for Leicestershire, that would be the Leicestershire donor effectively that we have, and in full partnership with our public health colleagues and our county council colleagues. So that's effectively what we're planning over the course of the next year, working with Mike and the public health team and John and team from a county council perspective, to make sure that any services that are designed at place level are right for these communities that live within that place, and take into account all the intricacies that I've just described of patients wanting to be seen in their own home by the right place, by the right person, and not being carted all over the place if it's safe to do so in their own homes. So Chair, that's really the update from us, that this is a plan in progress effectively, and we will continue to work in partnership with all of our colleagues across health, across care, and of course our citizens, to make sure that we can design the services that are right and not lose the learning that we've seen through the course of the pandemic. Thank you.
Thank you very much, Rashna. That was a gallop through what is I know a huge amount of work that is underway. Can I ask one quick question? And clearly you talked about it being sort of work in progress and being developed. I mean, at what point do you feel that you sort of have more to come back to this committee with sort of more concrete and firmer proposals, do you think?
So, Chairman, we've got various proposals already in play, for those types of services I've just described. So we don't want to wait to make sure that those services are ready for winter and those services are in place to keep our patients safe, particularly if we are going into a third or indeed a fourth wave, as our public health colleagues have indicated. So that kind of service delivery is already happening, and from a design perspective, going through what is known as the Integration Executive, which of course is a full health and care partnership group that represents Leicestershire. The actual place plans themselves, in terms of what we want to do for this place, is a much wider piece of work, and I'm afraid I can't give you a timescale effectively yet, because John Sinnott, John Wilson, Mike Sands, Sarah Prima and myself, we're still working through the intricacies of how we get some of this done, given that we're still in a pandemic, and the engagement that we want to do, our public have told us it works very well from a digital perspective for some, but not all. So we just want to make sure we've taken all of that into account. By all purposes, we would expect to come and give you a report at least in 2 months in terms of what those plans actually are going to look like, and when they would come in the sufficient level of detail that you could scrutinise them.
Okay, thank you very much for that. Okay, can I open up for any questions? Can I see if anyone has any questions or comments on the update? Nope, can't see any. So we don't have any questions for you at the moment. Oh, we do actually, Mr. King, Phil King. Sorry.
Yeah, thank you, Chair. Thank you. It's a bit weird having to look up at the screen and speak at the same time. So excuse me, Rashna, if I'm not doing that. Look, thank you very much for your interim report. Quite helpful, but I think it would be extremely useful in a couple of months to see a much more detailed written report, if that's possible, as to what the plans are. I mean, certainly, I'm aware residents in many district areas are very passionate about their local hospital, community hospital services and outpatient facilities, and have a lot to say about it, as I'm sure you and I both know, and others do as well. So I think it would be extremely useful if we were able to see some more meat on the bone, so to speak, in a few weeks' time. Thank you, Chair.
Thank you very much. Stuart Bray.
Yes, thank you, Chairman, and thank you very much for your presentation. As has been said, it's been quite useful to have that high level. I think from us as sort of local members, I think when we start talking about specifics about specific places and specific services, I think that's probably when we'll start to get excited about it. I think from my own district point of view, Hinckley, I was very fortunate enough to have a conversation with Sarah Prima, who's mentioned about some of the things that happened at Hinckley. And the comment that was made to her then, I'll make it again now, is that in terms of the Hinckley community facilities, which is the area I know best, is that people have got a little bit of consultation fatigue. We've been hearing so much consultation, and what people want to see is actually action on the ground. So I understand the importance of having consultation, but can I urge that is very much focused and we start getting actually some action on the ground rather than another consultation, which people have got consultation fatigue.
Thank you very much. Actually, we've got another comment as well. We'll save up any responses once we've got all the comments in. Amanda Hack.
Thank you, Chair. Just really quickly, it was obviously a bit of a whistle-stop tour of what's going on. You did briefly mention health and care coming together, and I didn't know if you could just delve a little bit further into that in a verbal update, if that's possible. Thank you.
Can't see any more hands up, so do you want to come back on those points?
Thank you. In terms of the consultation fatigue, I hope I haven't given you the impression that we are waiting to write these plans. As I said, we are almost gearing up now for the wave 3, which indeed we've learned is almost upon us, but wave 4 as well, which will hit in time for winter. So please, I wouldn't want to give the impression that we're not doing anything at all whilst we're doing these plans. I think the plans themselves, from a very, you're right, I'm sorry, I'm talking to somebody and not looking to them now. The plans themselves, you're right. It's when you get into the detail, it's absolutely when we start getting into the nitty-gritty of these. But what we have learned through certainly the pandemic is at the moment where we've got service provision in local areas, that's what we've been able to protect away from necessarily the big acute sites. So that's something that we're keen to progress, and certainly from a kind of a short-term point of view, the outpatient appointments and those types of things, if anything, will grow in those areas, because we know we've got to deliver those services specifically away from the acute site, because we just don't have enough space out there, and it's safe to deliver them in the community. So those types of things are absolutely happening. From a health and care integration perspective, we've got integrated teams. We have had integrated teams for quite some time now over the course of the last year. That's where our social care colleagues in particular are integrated with our health colleagues. You'll have heard of this concept called primary care networks, which is groups of primary care general practices effectively coming together. They at PCN level have named teams that work with them from a healthcare perspective, a social care perspective. They're called integrated locality teams. We have them set up all across Leicester, Leicestershire and Rutland, and they look after the most complex patients that need both healthcare and who need social care support, to make sure that we can make sure that they only go into an acute site if those patients need to. And when they need to be discharged, they're discharged back to a team who know them, and therefore are very less likely to be bounced across the system. So we've had that system in place across Leicestershire for quite some time, and indeed Rutland as well. So we're keen to build on that, especially given all of the relationships that have been built over the course of the pandemic. So if you think about the vaccination programme, it absolutely could not have been delivered without all of those joint working groups that we had across public health, across county council colleagues, and across the primary care network colleagues. So all of that has just strengthened our resolve to this is the right thing to do. We're going in the right direction in terms of the patient care that we need to deliver in the community. And indeed, from a relationship perspective, it's absolutely the best thing to do that we could do for this place.
Okay, Rashna, thank you very much for that. We don't have any other hands up or any questions. So look, thank you very much for your report. Appreciate the huge quantity of work involved that's going on at the moment, both, as you said, for the potentially coming wave 3, but also wave 4, but also trying to manage all the other changes that are happening alongside. So thank you very much for that. Thank you. Okay, we'll now move on to the next item, which is item 11. This is an item about the veterans from the armed forces, in particular spotlight on mental health. This will be presented by Mukesh, who's from Health Watch, and also in attendance we have Brendan Daly. Sorry, I've just changed your sex, Brendan. So apologies. Brendan Daly and also John Edwards, who are from Leicestershire Partnership NHS Trust, who will be responding to some of the points that Mukesh will present. We're taking all the reports as read, so by all means, no need to actually go through the report. However, Mukesh, if you wish to provide a short executive summary of any points in particular that you wish to highlight, then I will go to Brendan and John, who can respond to some of those points before we actually open up for general discussion and any questions. So over to you, Mukesh. Thank you.
Thank you, Chair, and congratulations to the Chair and Deputy Chair. Good afternoon, colleagues. My name is Mukesh. I'm the Chief Officer for Health Watch Leicester and Leicestershire. Our role is essentially to be the voice of patients and communities in regards to their experience or access to health and social care. The veterans work started prior to my time at Health Watch, and essentially was based on feedback from members of the public and local authorities through conversations about whether ex-armed forces veterans were able to access NHS or care services, and what their experiences were, whether they would be able to be familiar with the choices in terms of services available, and what their experiences were. So this report is, I would say, a embryonic stage of identifying some of the issues. Health Watch colleagues worked with Brendan and other stakeholders to identify what can be done in terms of improving the knowledge base and access to services from the Armed Forces veterans. As colleagues have mentioned in previous presentations, the pandemic was unexpected. We all had to respond very quickly to new ways of working.
Okay, we've got a small technical problem there. I think either that was the end of a sudden
remote working for staff as well as patients and communities. I'm sorry, say that again.
Sorry, Mukesh,
I'll carry on.
Suddenly froze and the sound went down. So
we lost the signal for a little while. So the report basically provides an overview of attempts to identify the experience of veterans, Armed Forces veterans. We identified that on the whole, access to GP services were quite good. There was a link between Armed Forces transition to civilian life, although there are areas that can be improved in terms of providing Armed Forces veterans with information about civilian health services. We identified in the report that the majority of respondents were from the Army as opposed to the Navy and the RAF, and there are room for improvement there. And in terms of experiences, we identified that on the whole, there was feedback from Armed Forces.
Okay, I think we possibly have actually lost Mukesh. He seems to have his line seems to have dropped. So possibly look. I think possibly if we can actually come to Brendan and John at this point. Mukesh is not rejoining at the moment, as far as I can see. So can I ask you? Obviously, you've had a chance to look at Health Watch's report. Whether it's possible to actually give any comments in response. Over to you, Brendan.
I think we've got Mukesh back.
Not back. Sorry, there was a signal loss.
Yeah, no, you suddenly dropped out, and actually we seem to have lost Brendan as well. So we are plagued with IT at the moment. It might be in this building, it might be elsewhere. But Mukesh, so you were just finishing the your quick summary, and then we'll go to John, who I think is still on the line. Hopefully.
Thank you, Chair. So veterans found that primarily they felt that there was a lack of understanding from the health services about Armed Forces life and how the issues of mental health, post-traumatic stress, etc., impacted on Armed Forces veterans as opposed to civilians. And therefore, the bulk of support was from family members, and there was a need to identify where consultants were involved, that they would have some knowledge or experience of Armed Forces impact in terms of mental health. I'll stop there. There are other areas, but I'll open it up for questions. Thank you.
Okay, thank you very much. Okay, so Brendan, I think you've come. Oh no, you're frozen again. So look, John, I'm going to come to you in that case, and if Brendan comes back on the line, then hopefully he can talk as well. So, if there are any comments that you wish to add in response to the report?
I think first of all, I think anything that draws attention to veterans' mental health is really important and welcome. And as you're probably aware, with our Gold Awards as LPT, we've really been focused on how we can really improve both the experience and the access to mental health support for veterans. Also recognise that the report perhaps struggled in numbers to get good feedback, which is a bit of a shame. I think that the general themes of how do we ensure through all of our organisations, through GP practices, through LPT buildings, through councils, are all promoting how veterans can access support and perhaps peer support offers as well, to try and attract people into actually talking and engaging in services and finding the right route, recognising that a number of veterans, which Brendan talked more eloquently than I, do sometimes struggle to recognise these institutions necessarily as being a help for them specifically. So I think we have done a number of things that Brendan can talk a little bit about that perhaps lead already to perhaps already on the least the journey towards meeting these some of these recommendations. And I think there's a wider context as well that we probably also appreciate about the up and coming, well, hopefully an up and coming bill that would also cement, and strengthen the approach to how we support veterans. But I'll ask Brendan to add a bit more detail about what's been in place at the moment, just to give you that flavour.
Yeah, good afternoon, everyone. I do apologise if I dropped out. I hope I'm back now.
You are.
Really?
Yeah, you are.
Thank you. Okay. With regards to the Armed Forces Covenant, as John alluded to, it's due for Royal Assent later this year. Consultation is due to start. And I take the point of the previous council saying consultation fatigue, but this is consultation, obviously parliamentary consultation that begins this month, and it's being led by 7th Infantry Brigade. The comments around GP surgeries, there currently is a scheme in place called Veteran Friendly GP Practices, set up by the Royal College of General Practitioners, which is not a mandatory service. It's one that is, as the previous speaker said, primary care networks can get involved with, and of course you would need quite a proactive and maybe a veteran friendly area or part of the county which is willing to sign up. There is no compulsion, but I understand NHS England are looking at rolling that out on a region by region basis, currently being rolled out across the northwest and northeast, where we have a high intensity or perhaps a more dense population of veterans per se. As John alluded to, we have set up the question of asking about, have you served in HM forces? Again, there is no requirement in law to do that, although at LPT we do ask that when people dial into our central access point, and we have an associated pathway that's been set up so that I will get to know any veteran who comes through our central access point, and I will work with them to refer them into what is now Op Courage, which was previously the TIL service. Just to sort of back on to LPT, we are Gold Award as members. We're part of the Gold Award alumni for the Armed Forces Covenant, and we are the first mental health trust in the United Kingdom to achieve veteran aware accreditation. And we hope through agile intervention, encouraging clinicians and GP surgeries to sign up, but that's all part of the VCHA, and that is something that is being developed as we come out of COVID.
Thank you very much, Brendan, as well. Rashna, you've got your hand up.
Thank you, Chair. I just wanted to add to something that Brendan talked about. So our governing body have appraised the veteran-friendly practices approach that Brendan talked about, and we had just before COVID a rollout plan about how we would roll that out, certainly to the majority of Leicestershire County and Rutland practices and some specific practices in the city. And as a result of that early work, we've already got, as part of our GP registration, a question which asks both whether the person has served in forces or whether they are a carer or a family member of those forces. So that's already been enacted. And I would just go to, I think there's the fourth recommendation, which talks about making sure that the Armed Forces Covenant is part and parcel of training for NHS professionals. Again, particularly where we've got veteran-friendly practices already accredited. That happens particularly in areas where we've got high concentration of forces personnel and their families already across Leicestershire and the Rutland areas. So just wanted to make sure committee was aware of that. Thank you, Chair.
Thank you very much for confirming that. That's very helpful. Okay, I'm going to go to members now to ask for any questions. Craig Smith.
Thank you, Chair. And thanks for the report. It was, really interesting reading through it as a veteran myself, and your findings and recommendations are welcome and received. However, I'm concerned that these are derived from such a small sample of veterans. And your report very much leans towards PTSD rather, as so do the media, when that's actually only a very small part of veterans' mental health. It's important to understand that when our service personnel enlist, they're quite literally forced together from all corners of the country, in fact, the Commonwealth as well. And very quickly, you form strong bonds and the unequivocal trust with your peers, and not to mention an appreciation of dark humour, which is absolutely vital and can be used as such a coping strategy as we're deployed. You're literally broken down as an individual and built back up, but not as an individual, you're back up as an interdependent team. And this goes on for the rest of your service career until one day when you hand your uniform back in, and that support network that supported you and literally been your parent for X number of years is instantly severed. And no calls afterwards to see how you're doing, no chats, and in my experience, no follow-up whatsoever. So many, if all not all service leavers, feel some sort of depression upon leaving. Some of us are lucky and are able to replace that network of social integration within the civilian world, but many are not. And sadly, this can spiral downwards to deep depression and anxiety. You cannot simply take a cog out of a mechanism and expect that cog to perform the same function by itself. I'm a firm believer that the only people that can help military people are in fact military people, as they get each other. I would argue that service personnel's mental health issues are unique to service personnel. It is very, very difficult for civilians to understand what we've been through or where we've been deployed to. So how can, as an organisation, can we direct and encourage service leaders to accept help from people and better understand the situations when such a small sample is where the recommendations are based upon? Thank you, Chair.
Thank you very much, Craig. Can we take any other questions before we actually go back? Amanda Hack.
Thank you, Chair. Just following on from Councillor Smith, really, in the sense that we talked in the pre-meet actually about the exit process from military life back into civilian life, and what's been done around that particular element of service. And I think one of the things that we also talked about is the way within which families actually also cope with the change, and whether or not that could be drawn out in some future research.
Thank you very much. Can I look for any further comments? Phil King.
Yeah, thank you, Chairman. Well, I'm not going to beat around the bush. This is a very disappointing report. The numbers involved are underwhelming. Whilst we've been in this meeting, I've just taken the opportunity to have a quick refresh in my mind of some work that was done between Harborough District, Rutland County Council and South Kesteven as part of the Armed Forces Covenant, which is actually work that was actually sparked off by Health Watch Rutland. Believe it or not, and we got some funding for this. We had over 700 people participate in that piece of work. 115-page report that's on our website, on the District Council website. A lot of it is related to health and social care. I'm absolutely staggered that this isn't linked to that. There is, phenomenal amount of good practice, knowledgeable people on the ground who could have got, I believe, even with the limitations of COVID, many more participants involved in this. And I'm absolutely staggered by this. I don't think it really touches the sides, let even the beginnings of the issues involved. And what I'm also, Chair, if I may, given there is so much effort being put into the Armed Forces Covenant, there is actually a committee that covers Leicester, Leicestershire and Rutland to deal specifically with the Armed Forces Covenant. So when somebody said that they had worked with other stakeholders, I'd love to know who those other stakeholders were, because we actually employ at Harborough, the District Council employs in partnership still with Rutland an Armed Forces Covenant officer. I just can't believe that we haven't engaged in that process. I mean, if we have, I'm staggered by the lack of response, quite frankly. So I think there needs to be a lot of very hard thinking here, Chair, as to what the worth of this report was. In hindsight, it's just really it's suggestive, but I don't think it's any more than that. And there are other pieces of work out there already which give a lot more information, I would say. And I think that's where we need to go. And even in your, is it in your area, Chair? Is it just outside the Stanford rehab facility? I mean, isn't that the National Centre of Veterans Rehab or something? Sorry, forgive me, I'm not sure exactly what it is, but I'm not sure if it's in Charnwood or is it just outside?
Some of the grounds are in Charnwood. So some of the grounds are in Leicestershire, but the rest of it's in Nottinghamshire.
But it's on the doorstep, Chairman.
Thank you very much, Mr. King. Are there any other questions or any other points that anyone wishes to make? Dan Grimley.
Thank you, Chair. It's just picking up on the point that Councillor Smith made, I think, about the having more military people involved with the look at these things and the rehabilitation. People in different ilks do understand what people have gone through before. I do a lot of work with a sports rehabilitation charity, and they find having a lot of pro sports people in there just helps them go along. So it's keeping the link of people who've been through similar experiences are very important.
Okay. Thank you very much, Dan. Right. Are there any other questions or any points? Mrs. Richardson, are there any points that you wish to raise as lead member on this item?
I think the points that I was concerned about have been raised. The numbers or a report, it would have been much better if we'd had a bigger cohort. I'm aware of the sorts of things that have come up through the report, having been on the community's portfolio and being on the military board alongside Brendan. So hopefully, I can forward this work and we can make some inroads. Thanks.
Thank you very much. Okay, thank you very much for that. Mukesh, would you like to respond to some of the points that have been raised? That would be helpful.
Absolutely, thank you. So first and foremost, I absolutely appreciate and acknowledge the low numbers in terms of participants for the report. This was due to a number of factors, including the staff turnover within Healthwatch Leicester and Leicestershire, but also the circumstances of the pandemic. We did actually, as I understand it, contribute to the bigger report that Councillor King referred to, so it was deemed that duplicating the same level of information was not useful, and also within the time constraints and what was happening last year with the pandemic. However, we do fully appreciate that one of the things that Healthwatch Leicester and Leicestershire wanted to do was to actually get the voices and experience of veterans themselves, as opposed to paid officials from local authorities or any other organisations. I didn't attend meetings, that I believe Brendan and other colleagues attended, but one of our focal points was to create a Armed Forces Veterans Forum, which would be a platform to get Armed Forces veterans to be able to participate and engage in case studies and breakout groups and discussions. But unfortunately, we were unable to do that with the lockdown situation.
Okay, thank you very much. Okay, thank you very much for the response. We haven't got any other questions or any other points that anyone wishes to make. Brendan, do you want to come back on that? Sorry.
Yes, please. Yeah, some of the points that were made with regards to the Leicestershire and Rutland Civil Military Partnership Board. I set that up personally 4 years ago. I acted as secretariat for that, and we have two co-chairs, and Councillor Richardson also sits on that panel. We're not regulated. We are a bunch of most of us are veterans ourselves. Most of us, not including myself, are former commissioned officers, and we try as best as we can as a non-regulatory body to, if you like, create an umbrella across the county to and where we can identify veterans to help them as best we can, either through signposting to the third sector or through other organisations or indeed the NHS Mental Health Service. It's interesting that there were mentions of transition out of service life. There is a big national research being funded by the Forces in Mind Trust looking at 2030 and better transition. It's widely acknowledged that transition out of service is poor. When I left in 1996, it was a shake of the hand. If it was a shake of the hand, there's the gate and thanks for playing. There are huge problems with not just its health, and I know it's often talked about post-traumatic stress disorder, but you have the things like where people have seen things that affect moral injury, hence the dark sense of humour that most of us who are served in the military have, and of course that level of banter. So I do accept that military services, whilst might be best served by former military personnel who get it, who get the banter, who get the dark sense of humour, that we still have that opportunity to educate staff in the NHS to create that better understanding, and that's something that I hope LPT will be able to take forward. And with regards to the work done at Harbour, Mark Harbour and South Stephen, I myself contributed to that from a health perspective and contributed to that report. I'm very much aware of the number of respondents they got, which was absolutely fantastic. And no such funding has been undertaken in Leicester and Leicestershire. And lastly, with regards to getting veterans in a room and a forum, I have managed to set up a Veterans Virtual Cafe, which is funded by the Armed Forces Covenant Fund, which meets 3 evenings a week between 6 and 7, where we get veterans coming on what is called a buddy-to-buddy check. And for those who have been in the military, we know what buddy-buddy checks are about. It's about looking after each other and making sure we're okay. That is something that started on May the 10th and will be running for the next year. So the work we have been able to do in the pandemic and during lockdown hasn't prevented us from getting veterans out of the community and onto a virtual cafe. That's what I'd like to add. Thank you.
Thanks a lot for that, Brendan. That's very helpful. John, is there anything you wish to add before we move on?
No, I think that's fine. I think our ongoing commitment, it will be a call to all of us that it's still going to require all of us to pull together on this. So I think it's just certainly from an LPT perspective, we've really have been passionate advocates of this, and we're as Rachna says, it's working with all our partners in GPs and I think in councils to really work together on this, because it is of increasing importance.
Okay, thank you very much for that. Well, look, thank you, Mukesh, thank you, John and Brendan, and an extremely important subject matter, spoken obviously with a lot of passion from those who have been in the forces, so quite certainly particularly for our area, as Councillor King mentioned, whether it's directly within our remit or otherwise, but we all have, I think, in Leicestershire, a huge stake in the future of and the care of veterans. So it's a subject matter that I know is close to many, many people's hearts. So thank you very much for your words, and thank you very much for your time this afternoon. Thank you. Okay, we're now going to move on to item 12, which is the paper from the Director of Public Health here at County on suicide prevention. So I'm going to ask Mike Sandys, supported by Fiona, who I think is online. Mike is with us in the chamber. I don't know whether you're going to be broadcasting online, Mike, or whether you're actually going to be talking to us, but either way, between Fiona and Mike, we should be able to cover the item. So over to you, Mike, I think.
Well, I'll go. Thank you, Chair. I can't resist the joy of using this third dimension, so I'm just going to speak. You know, I'm not used to it. I'm not going to say much, though. I need to introduce Fiona, who's going to take you through an executive summary of the paper, and then we'll open up for questions. But just to introduce Fiona, I think members will have seen her on the all-member briefing to do with COVID. Fiona started in our team in March of last year with a twin portfolio, really, mental health and health protection. And of course joined on the day after we had the first confirmed case of the virus in Leicestershire. So Fiona has only really known COVID in the last year or 15 months, but in between the cracks in the pavement is beginning to pick up some of the stuff around mental health and suicide prevention. So it's an opportunity to Fiona to take you through the suicide prevention stuff. So all yours, Fiona.
Okay. Thank you, Chair, and thank you, Mike. So this paper really is about, provides an overview of the work that's been done around suicide prevention in the county. and some of the issues related to it. So in terms of suicide prevention, it is very much a partnership approach, and the work is led by the LLR Strategic Suicide Audit and Prevention Group. And it really starts off from in 2018, Public Health were charged by the leader of the council with beginning a Start a Conversation campaign, which was very much concerned with developing a community that is committed to the health and well-being of its residents. And hopefully that's reflected in what we're talking about today. So the LLR strategic approach to suicide prevention was developed. So we have a strategy across LLR, which has been developed by this suicide audit prevention group. And it includes 9 priority areas that we focus on. So they include, for example, targeting those at highest risk of suicide, and for example, those with a history of self-harm. In terms of the data, we know that we have ONS data, which is the Office of National Statistics. So that most recent data relates to 2019. So historically, Leicestershire has had lower than the national average rates of suicide. So that most recent data is we were at 7.8 per 100,000 suicides compared to national average of 10.1. We are fortunate as a county that we receive what's called real-time surveillance data from Leicestershire Police, and that enables us to, that provides us with data with more recent unexpected deaths, which are believed to be suicides, but obviously haven't been through the coronial process. But that early sight of the data enables us to focus at an operational level in providing support to those affected or bereaved by that particular suicide, that particular incident. But it also enables us to be able to identify any emerging themes that we might need to focus on. So, for example, recently we did identify there seemed to be a slightly higher number of student suicides, so there was some work developed around that. So in terms of the work we do, we have weekly meetings, so those who operate at an operational level really look to respond to that real-time surveillance data and make sure that we do have an appropriate and timely response to those events. We also have quarterly strategic meetings, which are really focused on delivering that strategic approach to suicide prevention across LLR. So really, in conclusion, there is a whole raft of sort of interventions, including we have Start a Conversation website, we have campaigns, we've had an annual conference for the last 2 years, and we commission a number of services, so including counselling and support for those affected by suicides, and we also run suicide training. So we continue to deliver and to develop that work really under the auspices of that Suicide Audit and Prevention Group umbrella. So thank you, Chair.
Thank you very much, Fiona. Can I just pick up on a couple of points that are made in the report? Absolutely fascinating reading, but a couple of points on age categories in particular, just to be very clear what we're talking about. So on page 30, item 7, it references students, and I just really want to be clear whether that includes school age or whether it's specifically about university and college students. And the second point was actually item 10 on the following page. It talks about high-risk groups in Leicestershire, including middle-aged men. I think probably for my own benefit, I'd be welcome to actually know what the definition of a middle-aged man is in age category. But both of those points are quite helpful just to actually understand sort of the precise demographics of those two labels.
Okay, so in terms of the students, that does refer to all ages of children and young people in education. So it would include students in school as well as university. But just to say, there are very few students in school that tend to be included in those numbers, fortunately. And then in terms of the second question, middle-aged men, I think is around, it's 35 to 54, that sort of age range.
I'm just within that age range, but I won't let you guess which side. So thank you very much for that. Okay, look, can we have any questions in that case? I'm looking around the room to see if there are any questions. Councillor King, Mr. King, Phil King, you go first, and then followed by Amanda.
Yeah, thank you, Chairman. Thanks, Fiona, for your report. One of the questions I've got is there's a lot of programs for trying to create awareness, how to help prevent self-harm and suicide. How is it being evaluated? It's kind of a very difficult subject, isn't it, really? How do we evaluate, though, or how are you evaluating which of those programs are more effective than others? Which of those kind of techniques, if I can put it like that, are more helpful and positive in preventing, that outcome to occur? I mean, that's what it. So that's because there, as I say, there seems to be a lot of different things going on, and therefore, how do we really work out what works and what doesn't work? Thank you.
Okay, can I take Amanda's question as well, and then we'll come back to you, Fiona, if that's okay. So, Amanda, if you want to go next.
Yeah, thank you, Chair. I suppose there's a couple of things really. Is of those individuals that unfortunately decide to take their own life, do we have an appreciation of what services they were accessing before then, and whether they'd been identified at risk, particularly in light of the previous paper with regards to people being fearful of accessing services, and whether that was a factor. And secondly, we obviously identify that middle-aged men in particular are a key risk group. And this, sounds incredibly not insensitive, I suppose, but is that because they have a single attempt and that it results in a suicide? What do we have any details that sit behind that? Are other groups committing but not being? It's a horrible thing to sort of talk about, but actually have those, in terms of attempts versus those that actually have a suicide. I'd be really interested to see the numbers that sit behind those, please.
Okay, we don't have any hands up. Or actually, there's one more, Fiona, if I can take one more point, and then we'll come back to you. Mr. Smith.
Thank you, Chair. I read with interest about the Tomorrow Project. Obviously, this is about the suicide bereavement. Now, obviously, suicide is a tragic and terrible thing to happen, not more so for the people that are left behind as well and the families. And obviously, we see a lot of suicides then from that demographic. I was just wondering if you could explain a little bit more about the Tomorrow Project and how that can obviously prevent that tragedy happening.
Thank you very much. Okay, if you can take those 3 points in that case, Fiona.
Okay, so I believe the first point was about how we evaluate the impact of some of those more preventative programs of work, and to say that it is, you're right, it's quite a difficult thing to be able to do with any real accuracy, but we do monitor process outcomes. So we'll monitor the change, for example, in an individual's sort of mood and tendency to think about thoughts about suicidal thoughts, etc. So those kind of measures would be used and taken before and after an intervention to try to monitor that we've had an impact on that person's sort of mood and I suppose intention to take their own life. So that would be the type of measure that we use. I think the other thing to say is that we tend to adopt programs that have perhaps been monitored and evaluated in other areas, so perhaps nationally. So we would tend to use that type of program where there already is a level of evaluation and a level of effectiveness associated with them. Okay, so if I move on to the next question, which was really about, I think it was around middle-aged men, and there was something around middle-aged men. Yeah, I have heard this said, and I haven't seen the data to really support it, is that with their attempts of suicide, they can, and this is anecdotal, they can be more effective, if that's the appropriate word to use, in their attempts. But we do know, but also you will get middle-aged men who have several attempts. So it's not always a case of they are successful, if that's the appropriate term to use, at the first attempt. But there potentially is something around that they will tend to use particular methods that are more likely to result in what it is that they're setting out to achieve. And then in terms of people previously accessing services, we do get some data around, for example, the real-time surveillance data will often include details on whether an individual has previously accessed mental health services. And so we do work with that, and we do often look back and see whether or not there was any learning there to be gained. But obviously mental health services do work very closely with these individuals and are very much aware of the risks involved. And then if I move to the question about the Tomorrow Project, so the Tomorrow Project is a service that we commission from Public Health. It provides, essentially, it's bereavement counselling that it provides to friends, co-workers, family closely affected by suicide, and it will provide ongoing training sort of close to the actual incident itself, but they also maintain supports with that individual over a period of time. So acknowledging, for example, that sometimes the anniversary of a suicide can be a high risk point for some individuals, so they will continue to make those contacts and continue to provide that support on an ongoing basis.
Fiona,
thank you very much, Fiona. I think, Mike, you were going to add a couple of points.
Yeah, just remind me, Fiona, when the Tomorrow Project started, because I can remember the last conference before last, it was an idea to provide bereavement counselling, but it wasn't. It was only just an idea. In my mind, I've got it's a relatively new service compared to the other projects. Just remind me of that.
Mike, I'm not sure of the exact starting point, but it's been here for as long as I have. So I'd say it's been in place for at least a year.
Okay, thank you very much for that. Okay, Amanda, you've got a follow-on point.
Sorry, yeah, just a couple of things. In terms of the suicide bereavement, I'd be really interested to know how it goes back, because I think one of the things that is really problematic is the impact on families of an attempt, and on what long-term impact that has on that family unit, and how long that lasts. And a bit of personal experience here. My best friend from school, her father committed suicide when she was 14. And it lasts now, and that's 30 years later. And so it'd be really interested to also understand how far back you can get support. And the second point, and apologies, I raised it in the pre-meet and I should have done that at the start, was are there any risk areas in the county we should be aware of in terms of sites? So again, just from experience, it does feel like there's been a couple of incidents now on the Freds Bridge, which is going into Lubbersthorpe, and there certainly has been a number of points over the Lubbersthorpe Way, which there's another bridge that goes over Lubbersthorpe Way, and there's been quite a few quite recently, and I didn't know whether or not there was any particular work being done with highways or other colleagues in police services about risk areas across the county.
So, sorry, did you want me to pick that one up now,
yes,
Chair?
Yes.
Yeah,
that'd be good. Thank you.
So in terms of the how long we continue with following up those affected, those bereaved by suicide, the intention is that would take place, sort of going forward as far as we can, really, almost on the anniversary of the suicide. So almost that we would keep on revisiting it. But you're right, it is a good point about how long we continue it. And as Mike has highlighted, the service is relatively young, but it's something that it would be our intention to continue it for as long as it's feasible and as long as it's appropriate for those affected, because we recognise how important it is that we do sort of keep in contact with those individuals and those families affected. In terms of the high risk areas and the high risk sites, it's part of the strategic approach that we do work with partners to identify any sort of high risk areas. So, for example, some of the work we've done locally has not been so much around bridges, but although any information around sort of bridges or concerns of particular sites would be appreciated, because we don't always get that information, but a key area we have worked with is with British Transport Police, because we have had a couple of sort of situations at some of the railway stations in the county, and so in particular railway lines, and so that's where some of the focus has been. But certainly it would be our intention to work on those areas where we think there's a particular if that's a particular hot spot, we would need to look to address that.
Okay. Thank you very much, Fiona. Look, we haven't got any further questions or any comments from any of the committee members, so thank you very much, Fiona, for that. It is, as I mentioned at the beginning, you know, there is a partial link, I think, probably to the previous paper as well. Given the sort of subset of veterans within, I suspect, probably our own program on suicide prevention. But thank you very much for that and for answering the questions in the way that you did. I'm now going to move on. So thank you again for your time.
Thank you.
On that item. Right, we have finished the three principal items that we've had on our agenda. We're now on to date of the next meeting, which is agenda item 13. The next meeting is programmed for the 1st of September at 2 o'clock again. And on item 14 on any other business taken as urgent, there are no other items that we'll be raising at this meeting, so I'm going to close this meeting. Thank you very much. Thank you.